I'm Greg Ginsberg at the University of Pennsylvania. I'm co-moderating with Arkady Broder from St. Pete's in New Brunswick, and we're going to lead this session called Advanced Strategies for Tracking Malignant Biliary Obstruction and Ampullary Dysplasia Topic Forum. And so if we can bring to the podium our first speaker, that's Kazumi Ishikawa, who is representing his group and presenting on a comparative analysis of bilateral and unilateral preoperative biliary drainage in malignant hilar biliary obstruction, a multi-center study on cholangitis risk and future liver remnant hypertrophy after portal vein embolization. Doctor? You can advance using the arrow button. Click here.
Okay, thank you. Good morning, and thank you for the opportunity to present our research. My name is Kazuma Ishikawa, and I'm from Sapporo Medical University in Japan. Today, I'd like to discuss the optimal strategy for preoperative biliary drainage in cases of malignant hilar biliary obstruction, or MHBO. MHBO often requires liver resection. According to current Japanese guidelines, unilateral drainage (UD) is recommended to promote future liver remnant growth following PVE. However, most recent studies suggest that bilateral drainage does not hinder FLR hypertrophy. Preoperative cholangitis is a serious concern as it increases the risk of perioperative complications. In unresectable MHBO, studies have shown that BD tends to maintain stent patency longer than UD. Therefore, in this study, we compared UD and BD in preoperative MHBO patients. Our goal was to examine the following two factors. First, the risk of cholangitis, and second, FLR growth after PVE. We aim to identify the most effective drainage strategy. This was a multi-center retrospective study conducted from January 2011 to December 2023 across 5 Japanese hospitals. The inclusion criteria was as follows: planned resection for MHBO, bismuth type 2 or higher, and endoscopic biliary drainage before surgery. We measured the time to cholangitis from the last planned EBD to the onset. Laparotomy, non-resection, or reintervention for other reasons were censored. We also calculated delta FLR percent after PVE minus FLR percent before PVE. The statistical tests used in this study are shown on the slide: Fisher-Jacobs test, Mann-Whitney U test, Kaplan-Meier analysis with the log-rank test, and the Cox proportional hazards model. This slide shows the patient background. We analyzed 106 patients in the UD group and 57 patients in the BD group. The only notable difference was a higher proportion of men in the UD group. Other variables such as age and bismuth classification were well balanced between the two groups. Before final drainage procedures, some patients had undergone prior drainage with ENBD, inside stents, or EBS. The duration of prior drainage was slightly longer in the BD group. However, the difference was not significant. In the final drainage, ENBD was more commonly used in the UD group, while inside stents were common in the BD group. The BD group also used larger stents more frequently, yet the cholangitis rate at the final EBD was similar between the two groups. Most patients underwent major hepatectomy. The BD group had a higher rate of PV cases with 70% versus 46%, and waited a little longer for surgery. Radical resection rate was similar between the two groups. Here are the Kaplan-Meier curves. The overall incidence of cholangitis was 36% in the UD group and 28% in the BD group. Time to cholangitis was significantly longer with the BD group. The median time to cholangitis was 63 days in the UD group and was not reached in the BD group. At 50 days, the cholangitis-free rate was 77% for BD and 64% for UD. So BD delays cholangitis and reduces early obstruction events. In our initial Cox proportional hazard model, BD independently reduced cholangitis risk with hazard ratio of 0.51. Inside stents appeared to have a protective effect, but were not significant, likely due to overlap with stent size. Inside stent and large stent diameter were strongly correlated. To avoid collinearity, we constructed separate models for each variables. Model 1 included inside stent, and both inside stent and BD were found to be protective. Model 2 used stent size instead. Only BD remained significant. Thus, BD consistently lowers cholangitis risk. BD did not limit liver hypertrophy. Median delta FLR was 11.7% with BD compared to 7.7% with UD, contradicting the previous belief that BD restricts FLR growth. To summarize our main findings, bilateral drainage significantly delayed the onset of cholangitis compared to unilateral drainage. In multivariable analysis, BD, especially when combined with inside stents, remained an independent protective factor. Importantly, BD did not impair FLR growth. In fact, it slightly improved it. Taken together, these results support BD as a strong candidate for the preferred preoperative drainage strategy in MHBO. In conclusion, bilateral drainage appears to provide longer stent patency, lower risk of cholangitis, and does not interfere liver hypertrophy. BD, especially when combined with inside stents, may be the optimal preoperative drainage strategy for patients with MHBO. Thank you very much for your attention.
This paper is open for questions. Senator Mike?
I think I might have missed this, but I was curious the number of patients who ended up not going to surgery ultimately, or did you only look at patients who went for the surgery?
I'm sorry, but please repeat your question.
Were there patients, what was your number of patients who ended up not getting the resection even after they were initially planned for that?
Non-resection. Sorry.
How many patients did not go to surgery, and was there a difference in the outcome between those groups?
Nearly 80% of both groups were achieved radical surgery. 20% of patients did not underwent surgery. And outcome?
Yeah. Maybe you can have a sidebar. Can you define what you mean by inside stent?
The meaning of inside stent? Above the proximal end of the stent is above the papilla.
Suprapapillary placement. Thank you.
Thank you.
Thank you.
All right, good morning, everyone. I'd like to call up our next speaker, Dr. Erica Park. She's going to speak to us about the association between cholangioscopy procedures and cholangiocarcinoma diagnoses, a U.S. county real-world data analysis.
Okay, good morning. My name is Erica Park. Today, I will be discussing our findings from our study, Association between Cholangioscopy Procedures and Cholangiocarcinoma Diagnoses, a U.S. county real-world analysis. There we go. Here are our disclosures. Cholangiocarcinoma is a relatively rare cancer in the United States, but with a high mortality rate. About 8,000 people in the U.S. are diagnosed with this cancer each year, with the average age of cholangiocarcinoma diagnosis being in the 70s. The 5-year survival rate for intrahepatic cholangiocarcinoma is estimated to be 9%, and the 5-year survival rate for extrahepatic cholangiocarcinoma is estimated to be 11%. The incidence of cholangiocarcinoma in the Western world is rising, and this may be due to several reasons, including the increasing diagnoses of chronic liver conditions and metabolic factors such as obesity and diabetes. There are multiple different modalities that can be used to diagnose cholangiocarcinoma. More commonly available modalities include brushings for cytology with or without fluorescence in situ hybridization, and forceps biopsy, where a pediatric forceps may be used and fed into the bile duct under fluoroscopic guidance to the area of the stricture. Endoscopic ultrasound-guided fine needle aspiration has also been evaluated for diagnostic performance for extrahepatic cholangiocarcinoma, with prior studies showing that it is a safe and effective modality. An additional modality for diagnosis is cholangioscopy. Cholangioscopy allows for both direct visualization to aid in diagnosis and tissue biopsy for definitive diagnosis of cholangiocarcinoma. Prior studies have demonstrated that cholangioscopy has a high diagnostic specificity and accuracy in the diagnosis of indeterminate biliary strictures and suggest that cholangioscopy has the potential to facilitate earlier detection of cholangiocarcinoma. Prior studies have also shown increasing utilization of this modality in the United States over the past decade. At present, the relationship between cholangioscopy utilization and the rate of cholangiocarcinoma diagnosis remains poorly understood. So in this study, we aim to investigate the temporal association between cholangioscopy procedure volumes and subsequent cholangiocarcinoma diagnoses at the U.S. county level. Simply put, we aim to answer the question, is the use of cholangioscopy increasing in response to county-level increases in cholangiocarcinoma diagnoses, or is the increase in the number of cholangioscopy procedures associated with following year county-level increases in cholangiocarcinoma diagnosis? This is an ecological study at the county level using 100% Medicare standard analytic files. Our study population included patients diagnosed with cholangiocarcinoma or who underwent cholangioscopy between 2014 and 2023. Zero-inflated Poisson regression models were employed to evaluate the association between annual cholangiocarcinoma diagnosis volumes and prior year cholangioscopy procedure volumes at the county level. The reverse association, examining the impact of prior cholangiocarcinoma diagnosis on subsequent cholangioskopy procedure volumes, were also analyzed. Between 2014 and 2023, a total of 85,909 cases of cholangiocarcinoma and 23,902 cholangioscopy procedures were recorded across 3,038 U.S. counties. The annual mean volume of cholangiocarcinoma diagnosis was 2.5 cases per county, and the mean volume of cholangioscopy procedures was 0.05 per county. Poisson regression analysis using our count data indicated that prior year cholangiocarcinoma diagnosis volumes were not significantly associated with subsequent cholangioscopy procedure volumes. In other words, there was no indication that an increase or decrease in cholangiocarcinoma cases affected the number of cases where cholangioscopy was performed the following year. However, our regression analysis did show that prior year cholangioskopy procedure volumes were significantly and positively associated with subsequent cholangiocarcinoma diagnoses. Specifically, a 1-unit increase in cholangioscopy procedures in the preceding year was associated with a 24% increase in cholangiocarcinoma diagnosis. This result was consistent when volumes of cholangioscopy procedures from additional previous years were also included in the analysis. This study presents novel findings to help determine the relationship between cholangioscopy utilization and cholangiocarcinoma diagnosis. Strengths to our study include the use of real-world data and a robust statistical approach that was appropriate for the county-level data we were able to use. Potential limitations to our study to note include acknowledgement of potential confounding variables, especially knowing that cholangioscopy is an add-on code here in the United States, and there's likely underreporting of cholangioscopy in this country. Other limitations include, in general, low cholangioscopy volumes overall per U.S. county, and additionally, clinical implications to our findings remain encouraging but unclear and require further investigation. In conclusion, this study demonstrates a significant temporal association between cholangioscopy utilization and subsequent cholangiocarcinoma diagnosis at the U.S. county level, with no evidence of a reverse association. Increased cholangioscopy procedure volumes were correlated with an increase in subsequent cholangiocarcinoma diagnosis volumes the following year, suggesting that cholangioscopy may play a role in more frequent detection of cholangiocarcinoma. Thank you for your attention. I'm happy to take any questions.
Paper's open for questions. I guess the leading question for me is, how much of this is simply referral bias to the advanced center that is more apt to offer and have proficiency in cholangioscopy?
I think I acknowledge, that probably does exist, that referral bias. In addition, there's just small numbers of cholangioscopy cases used in general per county, as I saw in the data. So I think more studies have to be done. This is a county level analysis. So we looked at count data. It's not looking at like on the individual level, but I think that could help answer that kind of question more in depth.
Thanks. Looks like we have one gentleman who's slowly making his way to the microphone.
Quickly as I can. Were these patients who had failed standard biopsy and brushing diagnoses, or do you know that? And they went on to cholangioscopy?
So we did not look to see if any of these patients had gotten prior modalities used, because again, this was a county level analysis. All we did was look at essentially coding. So we looked at codes of patients who had cholangioscopy as a code for their cholangioscopy as code in their hospitalizations. And so we did not look to see if there was like an association between if they had gotten prior modalities or prior ERCPs with those modalities. No, not in this study.
Right, because it has major cost implications.
Definitely.
Okay. Thank you.
Thank you.
All right. So this next paper is being presented by Marco Spadaccini. He's representing a large consortium from Italy, France, and Boston. And this paper is entitled Advanced Cannulation Techniques versus EUS-Guided Biliary Drainage in Case of Difficult Biliary Cannulation in Patients with Distal Malignant Biliary Obstruction and International Multicenter Propensity Score Matched Analysis. Marco. Dr. Slivka and I were discussing this very topic before, so hopefully you will illuminate us. So just use the arrow here.
Yes, thank you. Good morning, everyone, and thank you for the presentation. So these are my disclosure. So we are talking about a really hot topic because in international guidelines, we know that biliary, US-guided biliary drainage is are suggested as the best option in case of ERCP failure. And one of the most important reason for a failure in ERCP is the difficult biliary cannulation. We know that in recent years, US-guided approach is helping us more and more in tackling this issue, and but we wanted to know how to proceed, because usually it is sort of a step-up approach, starting with standard ERCP technique, then going through advanced cannulation strategies like fistulotomy, papillotomy, or double guide wire approach. And just in case of failure of this kind of approaches, we proceed with the US-guided approach. And specifically talking about distal malignant biliary obstruction, the most used are the one implying the choledochoduodenostomy with LAMS. Usually we are getting more used to this procedure, and we are also starting in our clinical practice when we maybe had performed an US prior our drainage attempt, to proceed directly with the US biliary drainage. When I say directly, I want to highlight that I'm not talking about the direct US biliary drainage before ERCP attempt. I just talking about trying standard ERCP, and in case of difficulties in cannulation, proceeding directly with US instead of pre-cut techniques or other advanced techniques. So in our study, we wanted to analyze and compare the two strategies in case of difficult biliary cannulation in patients with malignant distal biliary obstruction. So proceeding with direct US-based approach, and we focused on choledochoduodenostomy, or proceeding with the historical path through the advanced techniques, so pre-cut and so on. And so we excluded patients with altered anatomy and concomitant gastric outlet obstruction, and also the ones with non-dilated CBD. So we included only patients with CBD larger than 12 millimeters. We focused on biliary drainage failures, clinical success, meaning the capability of bilirubin decreasing, and adverse events. Looking at the results, we collected data on around 1,000 patients, and 500 of them have a difficult biliary cannulation. We proceed in most of the cases with advanced techniques, but in the last years we tried to proceed with direct US-guided access in 52 patients. Then we to match these two groups, we go for a propensity score based approach, matching age, sex, and the CBD diameter. Looking at the main outcomes, we may see that the biliary drainage failure rate is higher with ERCP advanced strategy, but this may be, of course, expected since the US biliary drainage is a rescue strategy in these cases. The clinical outcomes in terms of clinical success wasn't changed. Looking at the adverse events, there is no statistical significance, but it is quite clear the trend showing that US-guided approach may have a lower risk of adverse events. So in conclusion, we should, of course, with the study, we do not want to say that every time we are facing a papilla that is difficult to be cannulated, we should go for US biliary drainage, but we want really to underline that this should be one of the options among the other options, knowing, of course, the CBD diameter before. The trend in reducing the adverse events is quite clear. And of course, to highlight it, to confirm this trend, we need a lot of more data. That's why we are increasing our samples. In this preliminary data, we collected data from 4 centers. Now we are collecting data from more than 20 centers, and considering we plan to close the data collection in a couple of months, if you want to be on board of this study, you'll be welcome. Thank you for the attention.
Questions for Dr. Spadaccini? I guess the glaring one for me is that these outcomes are influenced by a pretty high cannulation failure rate at 20% and a high adverse event rate at 20%. Do you want to comment on why you think that those were the case?
Talking about the adverse events rate, actually are totally in line with all prospective trials that are also published recently on this topic. 20%, considering there is around 8% of pancreatitis and 5% of cholangitis, are not so high as they may seem. But of course, considering it is a retrospective study, we have to confirm also the low rate of adverse events in the US biliary drainage group, that probably in the long term may go a little higher. For the cannulation failure, of course, the point is now that we know that we have a rescue strategy that may minimize procedural times, risks, and the technical complexity of the procedure. We know that we don't have to cannulate the papilla with this standard strategy at any cost. So maybe it may be influenced. Yeah.
I just want to give Dr. Bosco.
Good morning. Yeah, nice presentation. I just wanted you to follow up, I think, on what Dr. Ginsburg is asking about the adverse events. You know, I think from just a general perspective, using natural orifices and not creating new orifices to get access for drainage, I think is a preferable, approach. And I guess my question to you is the adverse events you saw in the EUS arm of this, can you clarify as far as the severity and not all adverse events are equivalent, I guess would be my comment.
Thank you for the questions. Of course, we analyzed also the severity of adverse events, and there is we confirmed the trend, but of course there is no significance. So I agree that theoretically the natural orifice route may be preferred, but we also, and that's why we usually start with ERCP, but we do not have to preserve this route at any cost, because the going for a pre-cut or going for pancreatic sphincterotomy is not something that may be done without any fear. So that's the point we wanted to highlight.
Thanks. We have maybe time for one brief comment. Dr. Slivka?
Yeah, thank you for the presentation. I'm just here to urge you not to expand your approach with more retrospective data in a larger group, because we'll never get a real answer, because there's so much investigator bias that's involved in when your threshold is to call something difficult, what kind of advanced techniques, And what time of day is it? And are you just going to pop a metal stent in at EUS for timing standpoint? You have to do a randomized control trial in this to answer this question. So I applaud your interest in pushing the field forward, but I would not get more propensity matched retrospective data. I would do it properly.
Thank you for the question. We have actually approved with our IRB a randomized controlled trial on this topic. But of course, considering the retrospective data as bias and with 4 centers, may have more bias than with 20, we hope to decrease the bias risk. Thank you.
I'd like to introduce our next speaker, Dr. Paul Levy. He can come up and speak to us about their experience with underwater papillectomy, a 12-year clinical experience.
All right, thank you so much for all being here, and thank you so much to the moderators. My name is Paul Levy. I'm a second-year gastroenterology fellow at California Pacific Medical Center in San Francisco, and I'm excited to share our results with you. We have no disclosures. Okay. So just starting with a little bit of background, endoscopic papillectomy was first described in 1993 by Dr. Ben Muller and has since proven to be a safe and efficacious treatment with curative potential for ampullary lesions. Some of the advantages of underwater EMR include enhanced visualization of lesions, a lower risk of injection-related complications such as perforation or bleeding, and the ability to resect larger polyps en bloc. As an extension of this technique, we performed papillectomy using saline submersion over a 12-year period at our center. So ours was a single-center retrospective study at our Quaternary Referral Center in San Francisco, California. We included all patients who underwent underwater papillectomy from January of 2012 to March of 2024. Using chart review, we looked at clinical history, endoscopic reports, and pathology records to assess safety, efficacy, and long-term outcomes of underwater papillectomy. All patients underwent endoscopic ultrasound to exclude extension of the mass greater than a distance of 1 centimeter into the bile and pancreatic ducts. Papillectomy was then performed under saline submersion using a caudal cranial snare technique for attempted en bloc resection in all cases. We used a stiff braided snare, the Olympus Snare Master, or the Boston Scientific Captivator 2. For cautery settings, we used AutoCut with an effect of 5 and 80 watts. All of our procedures were performed in a left lateral position, and all of our patients were intubated for the procedure. Biliary and pancreatic sphincterotomies and stent placement were performed at the discretion of the performing endoscopist. On the right-hand side of the slide here, you can see a patient undergoing removal of a 2-centimeter ampullary lesion using this underwater technique. Here are our patient characteristics. We had 107 patients in total during the study period. Our median patient age was 69. 52% of patients were female. The indication for papillectomy in the majority of cases was biopsy-proven adenoma. This represented 89% of our referrals for procedure. 14% of patients had a known polyposis syndrome at the time of referral for endoscopy. Other indications included biopsy-proven adenocarcinoma with 2 patients. 1 patient had a biopsy-proven neuroendocrine tumor, and 1 patient was referred for a bleeding ampullary lesion. Our median procedure time was 36 minutes with a standard deviation of 24 minutes, and our mean procedure time was 42.5 minutes. Of the 107 patients, 85 were able to undergo an en bloc resection with a rate of 79%. As I said, pancreatic duct stenting was left to the discretion of the endoscopist. 85% of patients underwent pancreatic duct stenting, which also represented 79% of cases. As far as complications, 10 patients had delayed bleeding, 11 patients had pancreatitis, and 2 patients had perforation, which ultimately required surgery. We were able, of the 85 patients who underwent en bloc resection, 70 of them had R0 resection, so that was 82% R0 resection rate. As far as pathology, the slim majority of pathologic diagnoses were tubular adenoma at 55%. 27% of patients had villous adenoma, 6 patients had an adenocarcinoma, 2 had a neuroendocrine tumor, and 11 had benign pathology. Of the 11 patients with benign pathology, the majority had biopsies done at their local referring hospital that was suggestive of a tubular adenoma with final pathology showing an alternative diagnosis such as a Brunner's gland hyperplasia. For follow-up interval, our median follow-up interval of the 80 patients where we had that data available to us in our EMR was 4 months. So here are those patients where we have follow-up data. Of the 80 patients, 65 did not have residual or recurrent adenoma on subsequent endoscopy. 15 patients had residual or recurrent adenoma. Of those, the majority, 10 patients, were initially had a piecemeal resection or were not R0 resection. 5 of those patients had R0 resection on their initial endoscopy. Of the 15 patients who had residual or recurrent adenoma, 13 underwent a subsequent retreatment endoscopically with no residual adenoma confirmed on their next follow-up endoscopy. 2 of those patients, 2 of the 15 patients with residual or recurrent adenoma were ultimately referred for surgery. So our findings show that underwater papillectomy at our center had a high technical success rate of 99%. En bloc resection was able to be achieved in 79%, of whom 82% had R0 resection. Residual or recurrence occurred in 19% of the roughly 80% of people who had follow-up. This represented a 7% recurrence of those who had R0 resection. Rates of post-papillectomy stenosis were low in our cases, only 5%, which has been reported up to 17% in the literature for conventional papillectomy. Our rates of pancreatitis and bleeding were comparable to current literature on conventional papillectomy, and we found no statistically significant difference in rates of pancreatitis in those who underwent pancreatic duct stenting versus those who did not, 10.5% versus 9.1%. In conclusion, at our center, underwater papillectomy had a high technical and clinical success rates, with en bloc resection rates approaching 80%. Pancreatic duct stenting did not appear to prevent pancreatitis in our patients. There was a high residual or recurrence rate, which highlights the need for surveillance endoscopy to achieve high clinical success rates in these patients. The majority of our patients, 95% in this case, could avoid surgery, with complications requiring surgery limited to only 2 patients for perforation. So thank you so much for being here this morning, and I'll take any questions you have.
Dr. Slifkin?
Very interesting, thank you. What was your expectation before you started doing these?
Yeah.
And then was that expectation met?
So I think the big, the advantage that we anticipated based on our prior work, taking out, doing underwater EMR for duodenal lesions, was that we'd be able to achieve high en bloc resection rates with limited recurrence. And I think that we were able to find that ultimately with our high rates of R0 resection.
Good.
For the papillectomy, just from the video, I was curious, were you guys using an EGD scope or a side viewer or a variety of both?
The majority were done with the side viewing scope.
Okay. And then for as far as did you instill the water for, so like when I do a colonic underwater EMR, it's nice because you can add water while you're doing the resection, but that's a limitation with at least the standard duodenoscopes that we're using. You just get the water in place at first and you had to do the resection without the ability to add.
Yeah. Having not performed these procedures, typically what we do is take a look, suction out as much air as possible from the stomach, and then go in and try to flood the lumen before removing it, and then just kind of like adding as needed. If that answers your question.
Thanks.
Dr. Norton.
Thanks. A. Norton, Sydney.
they were fairly small numbers, so it's hard to make any conclusions about whether the pancreatic stents really helped or not. But was there any severe pancreatitis in either group? Because one would hope the stents may not prevent mild pain, but they'd prevent severe disease.
That's a very good point. When I was looking at the statistics, I did not look at severe pancreatitis. I will say our rates of severe pancreatitis were low. The majority were mild or moderate cases, but that would be a good thing to follow up on.
So I know your group is very enamored with underwater resection, and I wonder how much it is skills versus gills. You know, in your group's hands, I imagine similar rates would be achieved, whether it's below or beneath the surface of the water. One, to use water or saline. Is it important? And second, as you're flooding the field with water, does that make your standard of practice endotracheal intubation to protect the airway in these cases for upper digestive tract resection?
Yeah, you're absolutely right. And to your first point, I think it might be interesting to see if there were any differences in conventional ampulectomy at our center with and compare that to underwater. Our cases were, we used saline submersion for the underwater portion. And your second question, I'm sorry.
Endotracheal intubation.
Oh, yes, and all of our patients are intubated as a standard of practice.
Yeah. You know, the interesting aspect, it's been hypothesized that underwater endoscopy promotes a floating of the neoplastic tissue to the surface, and you know, did that perhaps encourage a greater depth of resection that resulted in a small but not insignificant or not insubstantial 2 perforations? Yeah,
Absolutely.
All right. Thank you.
Thank you so much.
So our next paper is being presented by Clarence Kirsten. And this paper is coming out of a multi-center consortium from Netherlands, from Milan, and from Sydney. It's entitled Recurrence After Endoscopic Papillectomy for Papillary Adenoma, Risk Factors and Long-Term Treatment Outcomes. Thank you.
Hi everyone, I'm Clarence. I'm a gastroenterologist from New Zealand. I'm doing a fellowship in Sydney at the moment. I have no disclosures. We know residual recurrent adenoma occurs in around 12 to 33% of patients who have undergone endoscopic papillectomy. Data for RRA risk factors is limited. The management and the outcomes of RRA treatment is scarce, and salvage surgery is reported in 15 to 20% of cases. Our study aim was to identify and evaluate the risk factors associated with RRA and assess treatment effectiveness and safety of RRA management. This was a retrospective analysis of a prospectively collected database between March 2011 and November 2024. This was a single centre actually in Sydney. Endoscopic papillectomy of major papilla adenoma was the inclusion, and exclusions included minor papillectomy, aborted resections, adenocarcinoma or non-adenomatous resections. The endoscopic papillectomy was performed by one of 2 endoscopists, and from 2020, snare tip soft coagulation was performed of the margin after resection. Follow-up was standard 6 months after resection, then annually up to 5 years. RRA definition was histologically confirmed and categorised into lateral, then papilla and intraductal. Over this time, 215 endoscopic papillectomies were performed. The exclusions are here. We included 166 patients, of which we had very good eligible surveillance endoscopy at 97.6% in first follow-up, up to 73% at year 5. RRA was detected in 39 of 162 patients, that's 24.1%, of which the majority were found at surveillance 1, and then again, following that, 2 and 3. Mean age of non-RRA was 61 versus 66 of those with RRA. The majority were female and equal in both groups, and similarly with FAP in both groups. On univariate analysis, RRA was more frequent in larger lesions with intraductal extension, those with laterally spreading lesions, and with a longer procedure time. RRA was less frequent after en-bloc resection and after margin thermal ablation using snare tip soft coagulation. On multivariate analysis, including these factors on the right, this RRA was more frequent in FAP, those with increasing lesion sizes per 1 millimeter intraductal involvement. RRA was less frequent following margin thermal ablation using STSC. The location of the RRA was predominantly in the papilla alone. That was 2/3 of the cases, followed by lateral margin alone, papilla plus intraductal, and then finally in the papilla and lateral margin and intraductal alone. For this particular study, I'm just presenting the recurrence treatment of the 33 patients that do not include intraductal. Of the 33 patients, we performed 41 procedures. The majority had hot snare resection, followed by hot snare resection plus margin thermal ablation, and hot snare plus cast in 24.4%. Cast is cold avulsion and then snare tip soft coagulation. And then finally, all three, which was hot snare, MTA plus cast. And just a brief visualization of what that is. This was a very small recurrence on the left, on the top left image, which we hot snared off and then snare tip soft coagulation and PD stent insertion. This is a papillary recurrence, which we used cast, which is cold avulsion in the top right. The bottom left shows after the cold avulsion. Following this is the snare tip soft coagulation and PD stent insertion and biliary stent insertion in the final image. And this was a circumferential lesion which had no papillary recurrence but had a lateral margin recurrence which was quite large. Hot snare resection, lift, and then hot snare resection was attempted, followed by, in the bottom image, cold avulsion, and then in the bottom right, snare tip soft coagulation of the margin and of the defect itself. Of the 31 patients out of 33 that were attempted for recurrence for RRA, we had an endoscopic cure of 71.4%, 20 of the 28 who had surveillance, with a median RRA free follow-up of 22 months, IQR of 34. We had, following that, 6 had a second attempt. 4 out of those 6 had endoscopic cure. The third attempt, both did not, and the fourth attempt, one of those 2 had endoscopic cure, and that final patient is still coming back again for more endoscopic retreatment, with a total endoscopic cure rate of 25 of 28, 89.3%. Adverse events of the 41 procedures, 3 out of 41 had an adverse event, including 2 with post-procedural pancreatitis and 1 with delayed bleeding, which did not require endoscopic retreatment. In summary, RRA occurs in 12 to 33% of patients post-endoscopic papillectomy, and salvage surgery is up to 20% in some papers. In this study, we found RRA was in 24.1% of patients with independent risk factors, including increasing lesion size, intraductal extension, FAP, and STSC for margin thermal ablation was a protective factor. With hot snare cast plus or minus MTA, we achieved 89.3% with minimal adverse events. Thank you very much.
Thank you. You know, you slipped in that FAP component in the results section. You know, I wonder if you'd rethink the inclusion of those patients because they virtually have 100% local recurrence rate. What percentage of these patients had FAP as opposed to sporadic ampullary adenomas?
It was around 20% of patients.
So a big number, yeah.
Yeah.
Okay.
Yep, good thought.
That's great. So really applying the same principles that the Sydney group has proselytized for the colon can be applied safely and effectively in this area too.
Correct.
Very good. Thank you.
I'd like to invite up our next speaker, Dr. Aya Akras. He's going to speak to us about evaluating in-hospital outcomes among biliary interventions for malignant biliary obstruction in the United States.
Good morning, everyone. My name is Aya Akras. I'm a PGY2 internal medicine resident at HCA Florida Aventura Hospital, and I'll be speaking on in-hospital outcomes among non-surgical interventions for malignant biliary obstruction in the United States. So malignant biliary obstruction is a late and often complex presentation of pancreatic cancer and cholangiocarcinoma. Drainage is essential for symptom relief and for preparing patients for surgery or chemotherapy. However, with advances in endoscopic and percutaneous techniques, we now have several options, each with distinct benefits and risks. So ERCP is usually first line for malignant biliary obstruction. It's technically successful, has a wide rate of clinical success, but it has associated post-ERCP pancreatitis. The second option we have is EUS guided biliary drainage. It is less invasive alternative when ERCP fails, and it has a lower pancreatitis risk and shorter procedure times, but it requires specialized training. The third option is percutaneous biliary drainage. It's also an option when ERCP fails. It has a higher technical success rate. No endoscopy is required, and it's been shown to be superior to ERCP in unresectable perihilar cholangiocarcinoma. However, it does carry higher adverse events and mortality and requires external drains. So the objective of our study was to evaluate trends in the utilization of ERCP, EUS biliary drainage, and percutaneous biliary drainage for malignant biliary obstruction. We also wanted to compare procedure-related adverse events such as bile leak, perforation, and bleeding across these interventions, and perform sensitivity analyses based on the tumor type and location. And we looked at intrahepatic cholangiocarcinoma, distal and hilar cholangiocarcinoma, and pancreatic cancer. So we performed a retrospective cohort study using the national inpatient sample for the years 2005 to 2020. The inclusion criteria was adults admitted with malignant biliary obstruction due to cholangiocarcinoma, both intrahepatic and distal and perihilar, or pancreatic cancer. The intervention that we looked at was endoscopic versus interventional drainage for malignant biliary obstruction, including therapeutic ERCP compared to EUS biliary drainage versus PTBD, and the composite outcome of procedure-related adverse events was looked at. We performed a multivariable logistic regression to evaluate for the adverse events and subtyped the analysis based off of tumor type. So we were able to find nearly 200,000 inpatient hospitalizations between 2005 to 2020. And the majority of patients received therapeutic ERCP followed by percutaneous biliary drainage and EUS biliary drainage. These are the general characteristics of the three different groups. While they are statistically significant, they are not clinically significant. And if you look at the trends in utilization of these three different procedures, the proportion of utilization for ERCP and EUS increased significantly per year from 2005 to 2020, while the utilization of percutaneous biliary drainage decreased significantly over the same time period. And this kind of mirrors clinical practice. Regardless of tumor type, percutaneous biliary drainage and EUS biliary drainage compared to ERCP demonstrated higher odds of adverse events compared to ERCP. Now, if we subtype that by tumor type and location, you'll see that for intrahepatic cholangiocarcinoma, EUS was similar to ERCP in terms of adverse events. PTBD had a higher odds of adverse events compared to ERCP. For distal cholangiocarcinoma, including perihilar and extrahepatic, EUS was similar to ERCP for adverse events, and PTBD was similar to ERCP. For pancreatic cancer, EUS and PTBD had a higher odds of adverse events compared to ERCP. So the discussion. Procedural outcomes vary by tumor type and location. ERCP consistently demonstrated the lowest odds of adverse events overall. EUS-guided biliary drainage offers similar safety to ERCP in intrahepatic and distal cholangiocarcinoma and is increasingly utilized due to the minimally invasive nature and technical improvements and improvement in training. PTBD remains crucial to be considered for distal cholangiocarcinoma, and particularly when endoscopic routes are not technically feasible or have previously failed. In conclusion, collaboration between GI and IR is essential in the management of malignant biliary obstruction. There is no one-size-fits-all. Leveraging both endoscopic and percutaneous strengths to enable tailored and safer management of MBO is essential. Thank you.
We have a few minutes for questions.
Vivian Ortiz from WashU. Do you know if the procedure type that was chosen was stratified based on candidacy for liver transplantation? Because that definitely has a role, especially in those with perihilar cholangiomas.
That's a great point. I don't know, based off the retrospective nature, it may have to be coupled with different ICD codes, but I think we can look into that when we publish the manuscript. Thank you so much.
That's my study. Just the question I had, many of these patients, of course, we handle as an outpatient. So the question I would have is I'm assuming that this isn't capturing a patient we would bring in who has malignant biliary obstruction, do a ERCP or whatever we're going to do, and then send them home. Is that correct?
Yeah, it's an inpatient database, so it's someone you would bring in and,
So, often, there's bias, of course, we always worry about it. It's nice when the bias actually favors what we think is the right thing to do clinically, which I think may be the case here. But, I mean, was there concern that there may be bias because these patients who would be admitted, and I would assume I would include patients who might have a more complicated intervention and might have a, initial failed ERCP, and then you might bring them in and schedule the US for the next, so then you'll capture those patients. So was there a concern from you and your colleagues that there may be some bias to this? Though I think the data from people in the room would say that it sort of reflects what's reality.
Absolutely. That's something that's always there, especially because it's a retrospective inpatient database. And it's unclear whether these patients were admitted and then readmitted. We can't tell the readmission rate, but it could certainly be counted as different admissions. So I'm glad that kind of reflects what people are seeing in clinical practice.
Thank you.
Thank you.
All right, our last paper for this session comes from a large consortium from Italy, and I think it's being presented by Cecilia Blinda. And this paper is entitled Risk Factors for Acute Pancreatitis After Endoscopic Papillectomy for Ampullary Neoplasm to Stent or Not to Stent. That is the question. Thank you.
Good morning, everyone. Actually, I'm Chiara Coluccio from Forlì-Cesena Hospitals from Italy, and it's a great pleasure for me to be here to present the results of our study. Okay. These are my disclosure. So as we know, the endoscopic treatment for ampullary lesion is nowadays the first choice of treatment for this kind of lesion, although this is a demanding procedure and still burdened by a high rate of overall adverse events, which can rank up to 25%. And among all the adverse events, definitely bleeding and pancreatitis are the main issue for this kind of procedure, with in particular pancreatitis ranking up to 12%. And this is why over the years several studies addressed this topic, trying to find a method to lower the risk of acute pancreatitis. And this is why all the international guidelines, both from America and from Europe, recommend pancreatic stenting placement after this procedure to lower this risk. But actually, this recommendation is based on literature characterized mainly by retrospective study or small sample size study. For example, this is the only randomized control trial existing on this topic, collecting only 19 patients and published in 2005, which demonstrate a great benefit from pancreatic duct stent placement in terms of post-procedural pancreatitis. And this data was actually confirmed also by a meta-analysis published some years ago. But actually, these results still in a debated topic, as we can see in this meta-analysis published just some months ago, collecting 34 studies, and among these studies there are 2 randomized trials, but we should underline that one randomized is the one I talked about, and the other one is just an abstract. And in this meta-analysis, we can see that in the stenting group, the rate of acute post-procedural acute pancreatitis was not statistically significantly different for the no stenting group. So, as the topic is still debated, we decided to perform a retrospective study involving 19 Italian centers, expert in biliopancreatic endoscopies and ampullectomy, between a study period of 2016, when the first European guidelines has been published, till 2021. So the primary endpoint of our study was to assess the efficacy of pancreatic duct stent placement for the prevention of post-papillectomy acute pancreatitis. And secondary endpoint was to identify the possible factors associated with the occurrence of these events. Going to the results, we collected 414 patients, balanced in terms of sex. The mean lesion size was 20 millimeters. 20% of patients had a laterally spreading growth, and 80% of the patients received rectal indomethacins as prophylaxis, and 33% of the patients received intravenous hydration with lactate ringer in combination to heat or as an alternative. 27% of the patients had a submucosal infiltration prior to the resection. Pancreatic duct stent placement was reached in 85% of the patients, and the final lesion histology was balanced in terms of low-grade or high-grade dysplasia. The first surprising results of our study was the rate of post-papillectomy acute pancreatitis, which was a bit lower than the existing literature. It ranks 8.7%. And when we performed univariate and multivariate analysis, we can see that pancreatic duct stenting did not decrease the risk of post-papillectomy acute pancreatitis. And the only factors that results a predictive factor for acute pancreatitis was finding a low-grade dysplasia on final histology. So going to the conclusion, the pancreatic duct stent placement did not significantly reduce the rate of post-papillectomy acute pancreatitis in our cohort. The presence of low-grade dysplasia was the only predictive factor for post-papillectomy acute pancreatitis. Probably other factors should be investigated. We should ask probably if the attempts for PD cannulation can be itself a risk for acute pancreatitis. We acknowledge that definitely there are some limitations, the retrospective design of the study, and the low rate of acute pancreatitis in our cohort, but these are just preliminary data, and we are going to start a prospective study on the topic. Thank you for your attention.
Thank you. If I understand correctly, 85% of patients had a pancreatic duct stent placed.
Yeah.
And so you're comparing the rate of pancreatitis in that 85% group versus the 15% that did not have a stent.
Yeah.
Okay.
Which is a bit unbalanced, definitely.
So yes, maybe prospective analysis will be used.
Necessary.
You'd be comfortable randomizing patients to stent or no stent.
Yes, the problem of randomization can be an ethical committee because now guidelines definitely suggest the pancreatic stent, but
right.
Yes.
There are two other caveats to consider, and that is the recognized or not recognized presence of pancreativism, which may be a contraindication to prophylactic stent placement, and second would be, the impact of attempted but failed pancreatic duct stent placement, which I think wasn't teased out in this data.
Yeah, also probably the time necessary for the attempt.
Right. Dr. Sargent.
Nice talk. Did you look at patients who receive rectal NSAIDs and see the rates of pancreatitis in that group?
Yeah.
Like 78% receive rectal endomethacin.
Yeah, overall it was 8.7. Only in that groups it was 6%.
Did that make any difference with pancreatitis? No.
No.
Dr. Norton.
Greg, could I make a comment?
Yes, please.
We did a single center retrospective study of pancreatic stent placement and found no difference. And that led to a prospective single center study in the same place, which was Gavin Harewood's paper, which you commented on. And that showed a very significant difference in patients that had a pancreatic stent, which in fact led to termination of the study early. That's why the numbers were so small. So I just really, really encourage you to do the prospective study, because I think, I'm on a paper that I just frankly don't believe. It's been haunting me for 20 years. So the prospective data is really, really important because there's so many variables about the pancreatic stent placement, whether you could place it, whether you needed to place it, that sort of thing.
Yeah, thank you. I fully agree.
There's an online question from Dr. Coluccio. She asks, were there differences in cautery settings in ampulectomy in your data?
Differences?
In cautery settings.
Electrosurgical energy.
No. There was, but actually it's something that we didn't analyze because in a retrospective way was something different to ask to 19 center, but we don't have data about it.
Thank you. Thank you.
Good morning, everyone. It's a distinct pleasure and honor for me to introduce Dr. Amrita Sethi, who sort of really needs no introduction. She's a pioneer in the field. She's the director of interventional endoscopy at Weill Cornell, Columbia. She's also the president and founder of the organization Women in Interventional Endoscopy, really paving the way for women breaking those barriers. And we are excited to hear from her today. Wrapping up today's session, she's going to deliver the state-of-the-art talk on endoscopic management of ampullary adenomas and associated complications. Dr. Sethi.
Thank you so much for that very generous introduction and for the invitation to deliver this talk. These are my disclosures. So I just wanted to draw attention to basically the few resources when we're looking out there at guidelines. I think it's good to come back to guidelines, primarily from the ESGE guidelines, which are most recent. So ampullary adenomas, incidence is 1 per 100,000. and they make up 0.6 to 0.8% of digestive cancers. They can be sporadic form, which are the majority of them, versus patients who have genetic predisposition with FAP. In terms of types, they can be adenoma, intestinal adenomas versus pancreatic duct types that arise from Pannin lesions. And then, as we've seen, they can have lateral extension as well, so be larger duodenal lesions. Overall survival, 1-year survival is 89% for all lesions, including cancers, and 5 years is 47%. And the presentation can be found incidentally on endoscopy or patients presenting with obstructive symptoms, biliary colic, or acute pancreatitis. This is a reference to those guidelines that discusses the evaluation of ampullary lesions or suspected tumors that should include use of a side viewing scope, endoscopic ultrasound, and abdominal MRCP. And then we'll go into a little bit of what one should do with regards to negative histology and just an enlarged papilla. Then patients should have follow-up and not necessarily undergo ERCP and sphincterotomy, versus those who have obstruction can have a limited sphincterotomy and then undergo biopsy prior to any type of resection. Patients who have larger lesions, ampullary lesions, should be undergoing endoscopic papillectomy unless there's concern or suspicion for cancer, in which case patients, an intraductal extension greater than 20 millimeters, in which case patients should be referred for surgery. So, summary of endoscopic management is that patients can be surveyed if the lesions are less than a centimeter, there's no evidence of dysplasia, and they're asymptomatic. That the endoscopic evaluation, as I said, should include endoscopic ultrasound to rule out intraductal involvement, and the length of involvement should be determined. If it's less than 2 centimeters, then patients should undergo endoscopic papillectomy with snare, although ESD has been described in select cases for ampulectomy by specific ESD experts. And then we can think about ablation of residual disease with radiofrequency or APC. So ESGE definitely recommends against diagnostic and therapeutic papillectomy if adenoma has not been proven. So a little different than other polyps. It's important to distinguish ampulectomy versus papillectomy. We interchange those terms quite a bit. Ampulectomy is a surgical procedure that requires the removal of the entire ampulla vata, versus papillectomy is really just the tissue from the papilla, and therefore we can think about it as being a polypectomy or EMR, especially when we think about our outcomes that we're looking for, how to improve those outcomes, as well as the complications. But the unique considerations are the positioning of the papilla, the need for the side viewing scope, ductal involvement, and pancreatitis as a complication. So indications for papillectomy include biopsy-confirmed adenoma and dysplasia, lesions without intraductal extension or at least less than a centimeter intraductal less than 1 centimeter intraductal extension should be discussed in a multidisciplinary fashion to see whether or not patients can undergo more of a staging procedure with possible ablation versus need for surgery. Obviously, we talked about lesions with lateral spread can undergo papillectomy, the absence of a polyposis, advanced polyposis, and if staging is difficult. So in terms of the recommended technique, first, careful inspection to actually make sure that it does involve the papilla. Sometimes it can be hidden underneath the papillary mound. On-block resection is recommended for lesions less than 20 to 30 millimeters with hot snare. Submucosal injection is always a question. Guidelines actually suggest not using submucosal injection unless there's lateral spread, and then just for the lateral component. We do not recommend performing routine pre-sphincterotomy, although there are quite a number of differences in endoscopist technique on that. A cutting current is recommended compared to coagulation. And in terms of performing cholangiogram or pancreatogram, there's really no specific guidelines, but again, it is commonly practiced sometimes to look for lateral spread or if there's concomitant biliary stones or sludge. And then PD stenting is clearly recommended. We have, for ampullary adenomas with laterally spreading components, the recommendation is to treat the laterally spreading part first, and this can be done with our standard polypectomy techniques, such as hot stare, EMR. We just saw demonstration of underwater. There is a study that suggests a hybrid technique using cold snare and hot snare is not recommended because of increased risk of recurrence. However, there are no differences in adverse events. But basically, we want to leave the ampullary tissue to the end of the procedure so that we can take it off en bloc. So here, everything else has been removed, and just the ampullary mound has been left in place so that this can then be removed en bloc. Just speed that up. And then in terms of reducing the risk of bleeding and delayed perforation, endoscopic closure of the lateral defect is recommended, as it is with duodenal lesions undergoing EMR and ESD. So in this systematic review and meta-analysis performed by one of our speakers, including over 29 studies and 1,751 patients, in terms of the outcomes, complete resection rate of 86%, en bloc resection rate of 76%, a curative resection rate of 86%, and a recurrence rate of 11.3%. We'll come back to the complications. There was this study of 87 patients that looked specifically at outcomes based on whether the adenoma was confined to the ampulla, whether there was a laterally spreading component or intraductal extension. Here you see that there was, as expected, a significantly higher rate of en bloc resection when it's just confined to the ampulla. And tumor size also was significantly smaller in the intraductal, when there was intraductal involvement. I thought that was interesting. In terms of success rates, this overall was 77%, significantly higher with adenoma confined to the ampulla or with a laterally spreading component, as we would expect if there's intraductal involvement, was less. And patients were referred to surgery more often when there was intraductal extension. In terms of the complication rates, pancreatitis was really, there was no significant difference in any of these, but it wasn't really seen, interestingly, in this patient population. And then there, in terms of looking specifically at papillectomy for ampullary lesions that had lateral spread, this study just demonstrated nicely that there were actually no differences in the outcomes in terms of complete endoscopic resection and ability to clear lesions after the first surveillance. The biggest difference that was significant was in the bleeding rate, both intraprocedural and delayed, being higher in the laterally spreading group, somewhat consistent with treatment of duodenal adenomas. We heard in today's session, in terms of techniques, now approaching new techniques again, thinking about this as a duodenal polyp, so underwater papillectomy. The San Francisco group has nicely demonstrated the efficacy of this technique in providing better visualization, no need for injection, decreased risk of bleeding and perforation, and larger en bloc rates with polyps in general. The results we just heard today demonstrated an en bloc resection rate of 79%, RO resection rate of 82%, and with regards to the recurrence, that those patients who had residual could be retreated endoscopically in most cases, and also that there were no real differences from our typical techniques in terms of the complication rates, particularly pancreatitis and bleeding. Going back to this systematic review to look more closely at the complications, the overall complication rate was 25%. Again, pancreatitis is around 11.9%, and perforation 3.1%, and cholangitis 2.7%. Overall, the different types of complications that we deal with were with ampulectomy. You can see here, pancreatitis, bleeding, perforation, papillary stenosis is a rare but possible complication. And these are just some measures that are recommended to reduce those risks. And we'll discuss that now. In terms of pancreatitis, showing that study, the only factor on multivariate analysis that was protective or associated with decreased rates of pancreatitis was placement of a pancreatic duct stent. So therefore, the ESGE guidelines do recommend prophylactic pancreatic duct stenting, as well as use of rectal indomethacin and aggressive hydration, as we know from other post-ERCP pancreatitis studies. Today, we heard about a retrospective study of 414 patients in which pancreatic duct stents were placed in 85% of the cases. The acute pancreatitis rate was 8.7%, and on multivariate analysis, low-grade dysplasia was the only risk factor for acute pancreatitis, and the group made the conclusion that PD stenting did not have an impact on the rate of acute pancreatitis. But as the questions did ask, and it's a very important point, this conclusion can't really be made until we have prospective comparative data due to the significant differences in sizes of the groups between PD stenting versus not PD stenting. So it's important, I think, for now that we follow the guidelines. In terms of bleeding, bleeding rates range from 2 to 30%. This differs as well if there's a laterally spreading component, as we saw from the Australian study. You can perform standard hemostasis measures, such as now we have available gels, powders, and other agents to help stop bleeding. You can also use hot biopsy forceps or coagulation graspers. It is recommended to place a biliary stent, which is not a routine recommendation for post-ERCP for papillectomy, but this is to prevent cholangitis and also to help tamponade the bleeding. And of course, admission for these patients and monitoring for delayed bleeding. In terms of surveillance, patients should be brought back for their first surveillance endoscopy within 3 months, both for PD stenting removal, as well as to evaluate for residual disease or recurrence if it was an RSO resection. Again, the recurrence rate tends to be about 10 to 11%, with the median time to recurrence of 14 months. So ongoing surveillance is recommended for at least 5 years. If you perform recurrence, you do want to resume the evaluation, including potential endoscopic ultrasound and MRCP to look for intraductal involvement. And if it's benign recurrence, then we can think about APC or EMR, other ablative therapies. In terms of preventing recurrence, we heard very nice data from today of 167 patients who underwent papillectomy. 23% of them had residual or recurrent adenoma. 78 of these happened at the first surveillance. We heard about the different therapies that were provided, such as hot snare resection, hot snare and marginal thermal ablation with soft tip coagulation, cold avulsion, and snare soft coagulation cast, and then the combinations of those. The risk factors from the results demonstrated that RRA was associated with lesion size greater than 20 millimeters, intraductal extension, and a history of FAP. And it seemed that their lowest rates were associated with the marginal thermal ablation with the soft tip coagulation. Again, reflective of this group's data regarding treatment of large polyps. And we also got further data that it's almost 100% cure rate when those combinations are provided. In terms of ablative therapies, intraductal RFA is a device that can be performed during ERCP. It's a RFA catheter that you can do at the time of, that basically applies RFA energy within the duct. In this study, 29 patients underwent intraductal, RFA, and it was 100% technical success. The clinical success rates were excellent with long-term follow-up in terms of treating residual disease. So the ESGE does recommend that we can use APC or RFA for residual or recurrent lesions. In conclusion, endoscopic snaropalpectomy is recommended at this time for ampullary adenomas greater than centimeter. On block resection is recommended unless there's laterally spread tumors, in which case this is still effective therapy. PD stenting is still recommended. We cannot abandon this yet. We do need prospective data, and then ablative therapies can be used for residual treatment and intraductal treatment. Thank you.
Questions? Huh? Do you want to take any questions?
Sure.
Are there any questions following this spectacular state-of-the-art lecture? May I ask a question?
Sure.
I've got a personal axe to grind.
Uh-oh.
You know, lost in some of these sessions is the not so subtle nuance of the distinction between sporadic ampullary adenomas and those associated with FAP. And it's my hard-held opinion that FAP patients universally have ampullary or adenomatous involvement of the ampulla, and they virtually have 100% local recurrence, that endoscopic resection should be limited to those patients that have evidence of high-grade dysplasia or early cancer, and that we should not be routinely resecting ampullary adenomas in patients with FAP. Your thoughts?
I completely agree, and I think that is supported by current guidelines. There is a Delphi consensus group that has published very, very early data. There was no agreement on questions like this, but I do agree, and I think that that's why it's so important to establish sort of a plan with FAP patients in terms of classification, monitoring, and surveillance, that we are really following more FAP surveillance guidelines.
The guidelines don't provide, I think, very good guidance in this regard. All right. Thank you, Amrita.
Yeah.